And now I would like to hand over to Aristides to introduce our first speaker.
Welcome, everybody. It's always a great pleasure to join those webinars. As you can see here, we have a pretty packed agenda. So we're going to kick off right away. So it is my great pleasure to introduce Dr. Neil Scolding. Dr. Scolding is an emeritus professor of clinical neurosciences at Bristol University, and he's also a visiting professor at the Gulu University in Uganda. His main neurological interests in research have been centered around the clinical aspects in a variety of inflammatory brain diseases, including CNS vasculitis and sarcoidosis. Dr. Scolding spends around 6 months a year in Uganda, and he engages in developing clinical research, teaching clinical work, and establishing postgraduate education and training. And that's where he is right now. So he provided to us a pre-recording video on the clinical aspects of primary CNS vasculitis. So we're gonna look at the video and looking forward to your questions.
So good day, and thank you very much indeed for the invitation to talk. And my apologies for not being with you in person, but I do send my best wishes from northern Uganda, which is where I am and why I'm not with you in person. Cerebral vasculitis, CNS vasculitis, is a disorder which I think desperately needs guidelines. So this really is an excellent development. And what I will try and do is to offer a clinical perspective and a context for this guideline document. So why do we find CNS vasculitis so difficult? Why does it create such a complicated clinical problem? I think there are a number of reasons for this. First of all, it is an uncommon or even rare disease. So some years ago, we surveyed clinical neuroimmunologists across Europe, individuals who counted themselves as having particular experience in CNS vasculitis. And our results showed two things, I think. First of all, most people are making the diagnosis only 2 or 3 or 4 times a year. So it does take a long time to gain any real clinical experience of the disorder. And secondly, as you can see, 1 or 2 outliers making the diagnosis 20 or 30 times a year, strongly suggesting that we're not all applying the same diagnostic criteria to make the diagnosis. The second point is that there are really no specific clinical features of the disease that point to it. So again, we looked at a number of cases some years back, and there are a mixture of very diffuse neurological features, very focal neurological features, and the onset may be acute, maybe subacute, even chronic, and certainly can be relapsing. There's no specific clinical feature, no specific pattern. And this leads to it both being under-recognized, and we know from autopsy studies that a lot of cases are missed in life, but also overdiagnosed, and I think that's largely due to an over-reliance, should we say, on contrast angiography and even magnetic or CT angiography to make the diagnosis. That in turn reflects a difficulty or an inconsistency, I would say, in the literature on the definition of the disease, with many people, as I say, relying on angiography appearances, while accepting nonetheless that the gold standard is cerebral biopsy. The difficulty of angiography is that it has a recognized low sensitivity and low specificity, with a number of disorders mimicking the appearances, potentially mimicking the appearances of CNS vasculitis, so that diagnosis made by angiography in many ways can't be considered 100% secure. But of course, there are problems with biopsy as well, not least the fact that this is obviously a very highly inaccessible tissue. So a number of difficult problems, and we thought a number of ways there might be to try and address these problems, and perhaps first, particularly to prevent underdiagnosis, many cases being missed, is to try and find ways of simplifying recognition or initial suspicion of the disease. Second would be pathways, proper pathways to diagnosis, and that's a major area that this guideline concentrates on, combined with developing proper diagnostic criteria and categorization of the disease, which again the guideline addresses, before you can even think about proper ways of treating the disease, which is another key focus of the guideline. So in terms of initial recognition, we looked at this some while back again and found that all of our cases and the vast majority of cases in the literature will fall, in fact, into three clinical patterns. Now, these patterns have no pathological, no prognostic significance. They're not different disorders. They're merely the three clinical ways in which this disorder principally presents. And starting at the bottom, a minority present as an acute or subacute or even relapsing encephalopathy. A good number present as a conventional, if you like, space-occupying lesion, and a significant number present with a picture that superficially at least looks like multiple sclerosis, often with relapsing remitting disease, investigations that can also mimic multiple sclerosis, but often what neurologists would regard as red flag signs in making a diagnosis of MS, things that are not common in MS, such as encephalopathy, but also seizures or systemic features. And the vast majority of cases, as I say, fall into these categories. Of interest, large vessel stroke is not a major category. It's extremely unusual for CNS vasculitis to present as large vessel stroke. So with those three patterns, CNS mass lesion, atypical MS, or encephalopathy, the question then becomes, how do you move from that initial suspicion to making a diagnosis? And as I say, this is where the guideline gives a lot of attention. Essentially, of course, that process is the same process of conventional clinical medicine, looking at the clinical features, history and examination, various investigations, and then more tailored investigations before considering a cerebral biopsy. And those investigations or features at any stage may indicate a specific alternative diagnosis or maybe entirely normal. One thing I would want to stress, and this is perhaps particularly for the neurologists amongst the audience, is that it's important, crucially important, to pay attention to systemic features which may not be mentioned by the patient giving the history or the carer. These features are a meat and drink to internal physicians and rheumatologists, but very, very commonly overlooked by neurologists and may very crucially point to not cerebral vasculitis as a rule, but to alternative diagnoses. And again and again, with investigations as well, it's a recurring theme that the results can more commonly point to an alternative diagnosis than to prove CNS vasculitis. So then we move on to more tailored tests, and these are where the guideline questions of interest begin to cut in. So the first is on the value of cerebrospinal fluid examination, and there are no specific tests for CNS vasculitis, but again, CSF examination can crucially point to alternative diagnoses. Then MRI scanning, are there specific parenchymal patterns, or is the pattern of meningeal enhancement and thickening? Can that be diagnostic? And the answer to that second question, or the first as well, there's no specific parenchymal pattern. Meningeal thickening can be helpful, but is very much not specific for CNS vasculitis, occurs in a number of other disorders, but perhaps more importantly, does offer a reasonable target for biopsy with slightly less morbidity than aiming for CNS parenchymal tissue. And then various forms of blood vessel imaging, DSA and MRA, how do they compare? How do they compare with contrast angiography or other investigations? How do vessel wall imaging methods compare? Are they specific for cerebral vasculitis? Do they need to be carried out in addition to contrast angiography, in addition to MRA or CT angiography. One question not addressed is the value of whole body CT PET scanning, which again I think can be helpful in disclosing an alternative diagnosis, neurosarcoidosis, in this individual, and perhaps a future iteration of this document might include PET scanning. Then there's the question of cerebral biopsy. How does that compare? Is it showing something different to blood vessel wall imaging or the different patterns that are apparent on DSA or MRA? Are there histological patterns that can be used to prognosticate? Is autopsy more sensitive? And yes, it is. You will pick up far more on autopsy, perhaps not surprisingly, than biopsy. Just a word on biopsy, because it is something that I think most of us are extremely cautious about, but I think nonetheless remains absolutely vital in making the diagnosis. Most of the large series have arrived at really rather similar figures. Firstly, in terms of the hazards of the disorder, which are perhaps rather less than one might first have thought. And those figures there of mortality of just over 1 in 1,000, really not that different to, for example, renal biopsy, and around 10, 11 in 1,000 for major complications. And the findings, the rule of sort of 30, 30, 40 applies. About 30% you'll confirm a diagnosis of vasculitis, another definite diagnosis in 40%, and the others are non-diagnostic. And of that 40%, again, 30, 30, 40, 30% roughly will be a lymphoma, 40% infection. And this, I think, is crucial. Lymphoma has a very specific treatment, sometimes now very successful. Infections, of course, have very specific treatment. And infections, of course, are not helped by major immunosuppression. So it becomes vital, I think, to exclude infection by biopsy when, wherever possible. And then there are questions concerning treatment, the value of steroids, the value of mycophenolate versus cyclophosphamide, the value of long-term immunosuppression, and the value of aspirin. There are no randomized trials, so nearly all of these we're relying on expert opinion, and then perhaps particularly the experience of and trials in systemic and renal vasculitis. What about stroke when it does occur, large vessel stroke? The final two questions on the value of thrombolysis and clot retrieval. Our own preference is very much to go for induction with cyclophosphamide and steroids, followed by azathioprine, again on the basis that the systemic literature backs this up and shows shows azathioprine to be superior to mycophenolate in maintaining remission. So those are some of the clinical features and perspectives on the guideline. I think the authors of the guideline, I've not been involved in writing them, the authors are absolutely to be congratulated. There's a tremendous amount of work in addressing each of these 17 questions. And I think the paper provides a fantastic template for the future, directing where research is necessary and as that research is carried out. So I hope, and I think we will all hope, to see iterations of these guidelines ticking off the boxes and providing more and more proper evidence for the diagnosis and treatment of CNS vasculitis. So thank you very much again for the invitation to talk. I'm sorry not to be there to answer questions, and again, good wishes from Northern Uganda.
We thank you very much for this comprehensive presentation. Very interesting and excellent start of this session today.